Okay, let's be real. Medical research papers, they're not exactly what I'd call light reading, you
Yeah,
know.
I can see that.
Sometimes it feels like you need, like, a medical dictionary just to get through the abstract.
Uh-huh. Yeah, they can be pretty dense, even for us, and we're in the field.
Exactly. But that's kind of why we do these deep dives, right? We take those super complex topics and try to make them a little less intimidating.
Yeah.
So today we're diving into pneumothorax.
Okay.
And before you think new what now, it's basically when air gets into the space between your lung and your chest wall,
Right.
which, ouch, that doesn't sound comfortable.
No, definitely not. And it can be, depending on the type of pneumothorax and the severity. Anywhere from mildly uncomfortable to a serious medical emergency.
Okay, so you're saying there are different types of pneumothorax? I would have even thought about that.
Right, yeah. So there's three main types. There's primary spontaneous pneumothorax, secondary spontaneous pneumothorax, and then iatrogenic pneumothorax.
Okay, well, let's break those down because those are some big words. So first, primary spontaneous pneumothorax.
Right.
That sounds like it kind of just happens out of nowhere, spontaneously.
Yeah, so PSP, as it's often called,
Okay.
it usually affects young, otherwise healthy people, and they can just be going about their day, and then bam, all of a sudden they're having symptoms of a collapsed lung.
Oh, wow. So no warning signs or anything.
Well, that's where it gets interesting. So we used to think that these were perfectly healthy lungs, but it turns out that's not always the case. Research is showing that most people with PSP actually have some subtle abnormalities in their lungs that we can see on CT scans. Things like little tiny air sacs or blebs that are weaker than the rest of the lung tissue.
So they're just walking around with these, like, ticking time bombs in their chest and they have no idea.
Yeah, that's a good way to put it. Yeah. And it really changes how we think about PSP now. It's not just about treating that air leak, but also understanding what is it about these lungs that makes these people more susceptible in the first place.
Wow, that's fascinating. Okay, so then what about secondary spontaneous pneumothorax?
Okay. So SSP, this is when the pneumothorax happens because of an existing lung condition.
Okay, so that makes sense.
So think COPD, cystic fibrosis, even a really severe case of pneumonia.
So anything that's already making the lungs kind of vulnerable.
Right. Yeah. It weakens the lungs and makes them more likely to collapse.
Okay. And then that last one, you said iatrogenic pneumothorax.
Right.
That one almost sounds like preventable.
Yeah. So iatrogenic pneumothorax is actually a pneumothorax that's caused by a medical procedure.
Oh, so it's like a complication almost.
Yeah, exactly. It's essentially a complication.
Oh, no. Okay, so you go in for one thing and then you come out with a collapsed lung on top of it.
Well, it's not quite that simple, but
Right.
yeah. So any procedure that involved the chest cavity carries some small risk of pneumothorax. So things like lung biopsies, inserting a central line, there's always a chance, even if it's very small, that the lung could be nicked.
See, and that's where I would panic. I would be that 1 in a million that goes in for a checkup and comes out with a collapsed lung.
Well, that's why we have informed consent,
Right.
So before you have any medical procedure, you should know what the risks are, no matter how small, and be able to make an informed decision. But I will say, the vast majority of procedures go off without a hitch, and the benefits far outweigh the risks.
That's good. That's good to hear.
Yeah.
Okay, so I'm getting why knowing the type of pneumothorax matters, but like historically wasn't the go-to treatment always just sticking a chest tube in?
Yeah, pretty much.
That's what I always picture, at least.
Yeah, for a long time, chest tubes were the standard of care for, well, pretty much any pneumothorax. And, they're definitely life-saving in a lot of cases, but,
I can't imagine it's a very fun experience.
no.
Having a tube sticking out of your chest.
Yeah, there's a lot of, pain, risk of infection, longer hospital stays, all that stuff. So, not something you want to do if you don't have to.
Right.
And the good news is that recent studies have shown that a less invasive, I guess you could say more conservative approach can be just as effective for certain types of pneumothorax, especially that PSP we were talking about.
Okay, so by conservative, you mean like no chest tube.
Yeah, in some cases, yeah, especially if it's a smaller, less severe pneumothorax. Observation and monitoring alone can be enough for the lung to, heal and reinflate on its own.
Well, that's good to know.
Yeah.
Sign me up for the conservative approach if I can.
Right.
But I'm guessing it's not quite that straightforward for everybody. Like,
Right.
what about, if someone has those underlying lung conditions we were talking about?
Yeah, you're right. It's not one size fits all. So, if there's already some kind of lung condition present, like with SSP, the situation is much more, I guess, risky.
Makes sense.
Those cases usually need more immediate intervention because the lung is already kind of compromised and it can't bounce back as easily.
Yeah, you don't want to take any chances when the lungs are already having a hard time.
Right.
So, no tubes for some, tubes for others. How do they decide who gets what?
Well, this is where technology comes in, and it might surprise you. Remember those CT scans?
Yeah.
So it turns out size matters.
I've heard that before. I just,
Yeah.
not usually in the context of a medical emergency.
Right. Right. But we're talking about the size of the pneumothorax, which we can measure pretty accurately on those CT scans. And there's actually something called the 35 millimeter rule, which has become a kind of a big deal in how we think about treating pneumothorax.
Okay, so is it like bigger than 35 millimeters? It's like bad news? What happens then?
It's not quite that simple. It's more of a, I guess, a guideline.
Okay.
Studies have found that if the pneumothorax is smaller than 35 millimeters on the CT scan, you might be okay to hold off on the chest tube.
Okay.
And this is a big, but it requires careful monitoring to make sure it doesn't get any worse.
You're saying there's like a magic number, 35 millimeters, that can be the difference between like watchful waiting and a chest tube.
Right.
Man, I feel like I would be holding my breath waiting for those CT results to come back.
Right, yeah.
Like, come on, tell me, am I getting a tube or not?
It's definitely high stakes, but it's not just about blindly following the number, right? So the patient's overall health, their symptoms, is it a primary pneumothorax versus secondary? All of that factors into the decision-making process as well.
So even with these guidelines and like that technology, there's still some like judgment calls being made.
Yeah, absolutely. I mean, medicine is as much an art as it is a science. What works for one person might not work for another, even with the same size pneumothorax. It's about considering the whole picture.
So 35 millimeters is like a rule of thumb.
Right.
It's not like the end-all be-all. Okay, what about these studies you mentioned that support this kind of more conservative approach? What did they find?
Yeah, so there was one study by Brown and his team. This was back in 2020. They looked at a large group of patients with PSP and found that those who were treated with observation, meaning like no invasive procedures or anything, they had similar outcomes to those who got a chest tube right away.
Interesting.
Their pneumothorax healed just as well, and they had fewer complications.
So less poking and prodding,
Right.
faster recovery,
Right.
better outcomes all around.
Yeah, sounds good to me.
Right,
Yeah.
me too.
And then another study, this one by Halifax and his colleagues, also in 2020, found similar results. They looked specifically at people with small pneumothoraces, so less than 3 centimeters.
Okay.
And they found that, again, that conservative management was safe and effective for the vast majority of them.
Okay, so we've got some pretty good evidence to back up this shift toward a less is more approach. But I have to ask, like, why 35 millimeters? Like, what's so magical about that number? Is it just kind of where they landed after years of debate?
I think it's probably a bit of both, honestly.
Okay.
I mean, research is ongoing. Those precise cutoffs are still being refined. There was a large study by the American Association for the Surgery of Trauma
Okay.
that actually didn't find as clear of a correlation with size as some of the earlier studies.
Mhm.
But that study had some limitations, so, the jury's still out, so to speak.
Okay, so even with all this research and these fancy CT scans, there's still some, like, guesswork involved.
Yeah, it's kind of wild, actually, when you think about it. Like, something as serious as a collapsed lung, you just assume. Like, oh, doctors, they have this all figured out. But it sounds like there's still, like, a lot we're learning about the best way to manage it.
Yeah, and that's the thing about medicine. It's always evolving. We're always asking new questions and, testing new approaches, trying to find better ways to care for our patients. And that's what makes these research papers so important. They're kind of a snapshot of where we are now, but they also kind of point us towards the future.
So what does the future hold for a pneumothorax treatment? Are we going to be saying goodbye to chest tubes altogether?
Well, that is the million-dollar question, isn't it?
But there are some really exciting things on the horizon. Researchers are exploring ways to manage pneumothorax without needing those big, bulky chest tubes at all.
Oh, okay.
So one promising avenue is using one-way valve devices.
Okay.
So imagine like a small valve that's inserted into the chest. It allows air to escape from that space around the lung, but it prevents it from going back in.
Okay.
So the lung reinflates naturally, and the patient avoids all the discomfort and complications of a chest tube.
Okay. That sounds like a game changer, honestly. No more tubes sticking out of your chest. Sign me up.
I know, right?
Where's the clinical trial?
It has the potential to be really huge, really a game changer for patients, and that's just one example. Researchers are also looking at new ways to predict which pneumothoraces are more likely to get worse so that we can intervene earlier and hopefully prevent those emergencies. There's even some research into using medications to try to speed up the healing process.
So even though we're talking about something like a condition that's been around forever, it feels like we're on the verge of some like major breakthroughs in treatment, which is kind of inspiring.
It really is. And I think it's a good reminder that medicine is about so much more than just following the protocols, you know? It's about curiosity and innovation and always kind of pushing the boundaries of what's possible.
I love that. So for someone listening out there who, maybe feels a little overwhelmed by all this information, different types of pneumothorax and 35 millimeter rule and, all these new treatments,
Yeah.
what would you say is like the key takeaway you want them to remember?
I think the biggest thing is that if you're ever facing a pneumothorax, whether it's you or a loved one, remember that there are options. Treatment has come a long way, and we're getting better all the time at tailoring those treatments to each individual patient. So ask questions, advocate for yourself, and know that you're not alone in this.
That is great advice. It's so easy to feel powerless when you're dealing with something like medical, but you have more power than you think. Well, this has been fascinating. We took a deep dive into the surprisingly complex world of pneumothorax, from those kind of mysterious lung abnormalities in PSP to the potential for like chest tube-free treatment. It's amazing how much progress is being made even as we're, uncovering more questions to explore.
Absolutely. And that's the beauty of medicine, right? There's always more to learn.
Couldn't have said it better myself. Well, thanks for joining me on this deep dive into pneumothorax. Definitely giving us all something to think about. And for our listeners, until next time, stay curious.